All right, good morning. Welcome to what we call graduation day. As you've probably heard many times with your advisors and probably here again, it's not the end. It's just a point in time where we're curious to hear your story. So we heard your story a couple times already. Once in learning session 2 where you told us a little bit about what you were testing. And once in what we call virtual rounds, where you would have told us what you learned in your current state or what you learned as part of your testing again. So today is just that other point in time where we're calling it graduation because it's the end of the official program known as the Ideas Advanced Learning Program. But it's not the end of our relationship. And so we'll talk a bit about that at the end of the day. Before we get started, I'm just going to turn it over to Alice to do a bit of a land acknowledgement.
So just to make sure that I don't forget anything, I'm going to read from my phone. Toronto is home to a large Indigenous population, including residential school survivors and intergenerational family members who have been impacted by the history and legacy of the residential school system. The sacred land on which we stand has been a site of human activity for 15,000 years. This land is the territory of the Huron-Wendat and the Putin First Nations, the Seneca, and most recently, the Mississaugas of the Credit River. The territory was the subject of the Dish with One Spoon Wampum Belt Covenant, an agreement between the Iroquois Confederacy and the Ojibwe and allied nations to peaceably share and care for the resources around the Great Lakes. Today, the meeting place of Toronto is still the home to many Indigenous people from across Turtle Island, and we are grateful to have the opportunity to work in the community on this territory.
Thank you, Alice. Okay, so I forgot to introduce myself for those who are not a student in the course. I'm Joe Mauti. I'm a Quality Improvement Advisor with Health Quality Ontario, and I was the coach for a couple of teams in this room. So I want to say a few words before we kick off the agenda. The first is in your package you'll see a consent form. We need your consent to take your photo and record. Today's session is being recorded. So if you could just sign it and leave it on the table, we'll pick it up at lunchtime. So that's the first thing. And if you do not want to be recorded or photographed, then you would have to sit at your table when your team is presenting. But if everybody's given us consent, then we really do want the entire team up on the podium, either this podium or that podium, even if you're not speaking. It's just important for the people in the room to see who's part of the team and the people in the airwaves to see who's part of the team. So this today is being recorded. It's being broadcast live through the YouTube channel. So it's important that when you are at the podium, you speak in front of the mic, because then that way people can hear your presentation. We are dividing the room into half, so that wall over there is going to come down. We'll make sure that it's announced, so people like John with their back to it aren't going to get clipped. So just, we're dividing the room in half for the team presentations, but everything that's common, the walls will come up. So at lunchtime it'll come up, and then the closing speaker will come up as it is this morning. All right, so let's, some housekeeping. So I told you about the consent form. There is a change in the agenda. So Anna Greenberg, the interim president and CEO of Health Quality Ontario, is not able to provide closing remarks. She unfortunately fell in the slop last week and has fractured her ankle. So Lee Fairclough, our Vice President of Quality Improvement at Health Quality Ontario, is going to fill in as our closing speaker. All right, the posters are up. When you present, the posters will not be on the screen, because last time we saw a huge distraction with people looking at it, and so it's very small to look at it. So that's why we encouraged you to create a speech and tell us your story. So what you see here is what will be on. But the posters are on the walls. We recognize that half of you will not hear the other half. But if you're interested in what they had to say, you know, during break, lunchtime at the end of the day, you can take a look, see what's been done. And each team is welcome to take their poster home at the end of the day. Alice, were there elastics with it, or people are just going to use their gum? Okay, so there's no elastic to wrap it up, but don't fold it in 4 pieces. Okay, so remember when we met the first time as a program back in August? There was a welcome webinar and we showed you a slide that said the Ideas Advanced Learning Program has 4 components: learn, do, share, and sustain. And so throughout your experience, you've been doing a little bit of each. Today we're going to be sharing your update of what you've been able to experience in the last 5-6 months. But that doesn't mean we're not also going to be learning. So we do believe in the IHI philosophy of all teach, all learn. And today, as you're telling your story, there's going to be so many connections being made. And so we hope that you also receive some ideas, some motivation to continue testing. Because if you haven't shown improvement, your job is not to call it quits. Your job is to go back, look at your diagnostic information, and try something different. So remember the definition of insanity that Einstein told us. If you continue to do the same things over and over again and expect different results, you will go insane. So please, don't see this as an end, but just a point in time. All right, after we close the walls, we'll talk about the process of, you come up on your left, go on your right. We'll introduce our panelists at that time. But right now I want to introduce Ross Baker. He's our opening speaker. Ross is the program lead for the Masters in Science program in Quality Improvement and Patient Safety at the Institute for Health Policy Management and Evaluation, also known as IHPME. You have to work many years to practice that acronym. And he's also the co-lead for the Ideas program. So he's going to say a few words for us. So welcome, Ross. Come on, now remember, that's it. Let's show our appreciation for everybody. Please. You can use the slides? Yeah. So Christian, you could turn on the slides for him.
Okay, so good morning, everybody, and welcome to this session. You probably in August didn't look ahead to think of what February would bring, besides bad weather, and the learning and experiences you've had here. I hope it's been wonderful for you. I had the great pleasure of being part of the group that planned Ideas, and we said at the time, we need an engine of change in Ontario that gives people the skills and knowledge and the confidence to make evidence-based changes using quality tools to really improve our healthcare system. And that, projection, that plan has become a reality now for almost 6 years. So really pleased to be working with the great Ideas team and the support that we get from the IHPME group, the HQO group, the ISIS group, and executive sponsors from all those organizations. So I'm going to say a little bit more that sort of provides a context and reflection for the work that you've been doing. And I want to say to you, like Joe said, that this is not the end. This is just the end of the beginning. So I think there's still lots of opportunities to learn and to do better. So our goal with this program, and we're going to get some feedback from you on whether or not we've achieved this goal, was to provide you with the knowledge, the skills, the coaching, the support necessary to create the changes in your own environment that are going to provide a better experience and better outcomes for patients and clients, a better work environment for individuals within that setting, right, and a better system for Ontario. Piece by piece, right? It's a big job, and we're still only engaging with relatively small numbers of teams, but we're trying to populate the environment with people who speak the language, understand the tools, and make a difference. And this idea that quality improvement is an engine of success is a necessary element, is not original with me. Many people with much higher profiles than me have said this and made this point repeatedly. One of them is Gary Kaplan, who's been for, I think, almost 20 years now, the CEO of Virginia Mason Health Center in Seattle, Washington, which is one of the premier places in the world. I had the opportunity to visit about 10 years ago, and you thought you were on a different planet, right? Because people talk and work and act in a different way. And so with a group of colleagues from across different systems, he wrote this article a few years ago in BMJ Quality and Safety, underlining this idea that quality improvement should be a fundamental part of every organization, every part of the organization. It's not a side activity. We manage the organization, then we do quality improvement. We plan for the future, then we do quality improvement. It's something that should be embedded. And why is that? Because quality improvement is fundamental to our ability to improve the healthcare system. Now, you know, this is a very interesting time in Ontario healthcare, and we don't know. We can see what's going in, and all this discussion. If you follow Twitter, it's really quite interesting, the variety of views that you hear expressed. And most of the changes that people are talking about are these big system realignments, big policy changes, big agency changes. But the reality is that healthcare improves, not because we have a really good funding system or a really good regulatory system. It improves because of the work of people on the front lines across all of healthcare. And frankly, in the connection between health and social service and other parts of the organization. So the system we have to think about these things as being a big system. But the system is composed of many people like you who have a daily responsibility to deliver care. And Sven-Olof Carlsson, who was the CEO of Jönköping Healthcare in Sweden, used to say, with great emphasis, that he said, everybody who comes to work for me in Jönköping, which is a premier place in Sweden, everybody who comes to work has two jobs. They have the job that they're hired for, and then they have the job to improve the work that they're doing, right? So it becomes a requirement across the system to think about the opportunities to change. And I have to apologize a bit now, because what we didn't tell you coming in is that you're not only learning a set of tools and knowledge, you're learning a mindset. You're seeing things in different ways. So we've destroyed your opportunity to relax when you see these long lines, either in healthcare or in the lunch lineup, or in the wait that you might have somewhere to get a service. Because now you can see that doesn't have to be the case. It's something that we can change. We can make improvements with relatively limited resources as long as we have the right elements in our system. So you've all learned a variety of tools, and you've also learned this important lesson, which is that although it all looks very simple, it's not really easy, right? So part of the reason why we have coaches is that we have people who are experts in understanding how to address these problems with the tools. And it's not just a technical issue, it's a leadership and teamwork, adaptive thinking kind of issue, right? So if you want to be successful, just knowing what the tools are is not enough unless you understand the team that you're working with, both the immediate team and, for many of you, that team that exists in other settings where your patients start or where your patients go from across the system. So that's a big agenda, and it's great that you're where you are right now. And so what I want to leave you with is really two sets of ideas here about the next step. Part of it is around your projects, how to sustain your projects, and we do have this great sort of resource of the coaches who will continue to work with you. And part of it is around your personal learning. What can you do yourself to understand how to improve and improve your improvement knowledge? And the metaphor I like is a sailing metaphor. How many people are sailors in this room? Yeah, okay, see a couple of hands, right? It's not the time of year that people think about sailing in Ontario anyway, but you might go south. So this is the view of a stern of a large sailboat. I think it's a stern. Anyway, the issue is waypoint, not endpoint. If you're sailing a course, every adjustment you make in the course goes around a waypoint. It could be a buoy, it could be an island or something. So you're rounding this major waypoint of understanding and graduating from ideas. And congratulations on that. But there is other tasks that you have to finish in order to continue your journey, thinking about the changes you could test, thinking about the other projects you could take on, and holding the gains in your current project, as well as your individual learning. So let me just say a little bit about what I see based on some of this literature and based on the experience from previous ideas teams about the keys to sustaining and spreading improvement. And there's 7 of them here. So part of it is around measurement. Measurement is a very powerful tool, right? And I think some of you have had your eyes open because you always thought as measurement as something that was very distant, right? People hand you tables of measures. It's not something that you're intimately involved in yourself. But actually, measurement is something that is a personal skill that's very handy. And it's not advanced calculus measurement. It's that ability to see what the right numbers are that we want to track over time. So I'll talk about that. Leadership is a key theme. And with leaders, the way to engage leaders who are very stressed in this current environment is to talk about things that they really care about. So clarifying the linkages to leaders. Thinking about the goals of your project, not just in terms of patients, although obviously patients are critical, but in terms of what happens to staff and what happens in the organization. Thinking about, although we like to say that quality improvement uses our existing resources more effectively, there are times when you need to augment existing resources to get additional ones. Engage staff, build their capabilities, their understanding of these tools that you've mastered in the last 6 months or so, and then focus on adaptation. Standards are important, but it's the adaptation of standards to local environments that's the critical piece. So I'm going to talk about these in just a little bit more detail, using some examples from some of the early ideas teams. So one of the early ideas teams was working on developing coordinated care plans for complex older patients in health links. And this was a team from Sunnybrook that came, and they were measuring their success in terms of the number of care plans that they developed. And they had a target, as you can see there, and then they were tracking their success over time. And this is a very simple graph, and the message is really easy to see, which is that they started to do really well, and then it just fell apart. Now, we all have these experiences, right? And so part of the challenge is to figure out what to do. And so they went in, they drilled down on their experience, and they discovered that the reason why the triad, which was the patient, the family physician, and the home care coordinator, the reason why the triad didn't come together to agree on the coordinated care plan was, as you can see, the issues here. Partly that some of these patients didn't have family doctors, but that wasn't the important issue. It was that they were unable to communicate to the family doctor to get he or she involved in this. And sometimes they were unable to reach the patient. Those were solvable issues, right, that they could deal with moving forward. Leadership, I've already said leadership is important. The key thing about leadership is not to have this mindset of saying the leaders are at the top of the organization and everyone else is, not a leader. The reality is that there's leaders throughout the organization. You can be a leader in your team. You can be a leader as an executive sponsor working with the teams, and you can be a senior leader. And you get disproportionate amounts of time. You get most time from the leaders that you work with on a daily basis. And those local champions are absolutely critical to making a difference. If you work on a team where somebody understands the importance of this work, things can go very smoothly. If you work on a team where the local leader says, you know what, this isn't my top priority, it's much tougher, right? So continue to have conversations with your leaders and reinforce the people who see this as an avenue forward, and help people who don't see it as an avenue forward to understand what value it brings to your projects, to continue to work on them. And as I've already said, leaders have priorities, and they have a culture that supports the work that they see as not only providing the daily care, but influencing the larger direction of the organization. And this is a project that came from Toronto East General Hospital, again, pretty early in ideas, where they were focused on this issue of trying to identify ways to improve the flow through the ED. And one of the issues is patients in long-term care who, at the least sign of some problem, get bundled up and sent to the emergency department. And so the team said one of the things we need to do is to understand which of these long-term care residents are at risk of transfer to the ED, and then provide a little more oversight so we can manage them better and perhaps avoid these transfers to the ED. So that's a priority for the organization, and the organization thought this is a great thing, and they stepped behind and supported the team. And Chris Hayes has this idea of sustainable adoption of quality improvement, moving beyond the benefits for patients and engaging staff, because they realize that not only can we have better outcomes, we can also create a work environment that doesn't add additional work for this. So it's not all quality improvement is of that way, and we'll come back and talk about what it's like when it's not that way. But if you can identify changes that make work easier for nurses and doctors and other staff, then it's more likely that people are going to want to adopt those things. Seems really obvious, but you can't believe the number of teams that come up with these complex number of changes, and then they go to the staff and say, oh, well, we've solved this problem. Here are the 15 things we need to do in addition to our daily work. And it doesn't win a lot of friends. So one case where this was really clear was in Markham Stouffville Hospital, which had a project to increase the patient discharges by 11 a.m. They wanted to get to 30% of all people scheduled for discharge that day to be out of the hospital by 11 a.m. And they did a variety of things to make that happen, but they realized that it needs to be somebody who's owning that process, who will do this in a way that we can get those patients out. And so they created a business case to use a nurse practitioner, additional hours on a nurse practitioner to achieve that performance improvement. And the hospital accepted it. So sometimes you do need to add more resources. And London Health Sciences, similar kind of issue, but on a much smaller scale. So they were working on mobilization of patients, early mobilization, prevent a patient deterioration in inpatient units. And we all know that's a problem, but busy staff have a hard time spending time on early mobilization if they have many other things to do. So they worked on a variety of PDSA cycles. They won an award that year for the best PDSA cycles among all the IDEA team cohort, and you can see why. But one simple idea that they had was, let's buy a little more equipment. Let's have a few more walkers and other things that are going to help our patients mobilize so we can put them through the unit. Because if a nurse has 5 minutes to mobilize a patient, but the walker is 3 minutes away, it doesn't happen, right? So blindingly simple idea, but also brilliant, right? And they sold the hospital on that idea. And engaging staff, building capability. So here's the problem. So you now know more about quality improvement than many other people in your organization. And so if you want to have this conversation with them about what you're doing, right, you have to translate, right? Is that your experience? Or does everybody understand what quality improvement is so you can just launch in and tell them what your last PDSA is, right? In organizations where that's the case, and there are some, right, it's a different conversation. But you now have to help others understand. And there's many people who are doing that formally and informally. And one of the best examples of this is this team from St. Paul's Lamoureux, which is a day program in Scarborough. Now, everybody is stressed in terms of resources these days. Believe me, day programs, day hospitals are not well funded, right? So they said, we don't have much resources to do this, but we can have staff who do little bits on an ongoing basis to share this information about our quality initiatives and to help interest people and bring them up to speed on what we're doing. And then lastly, this critical idea of local adaptation. So I don't know if have you ever been in a meeting where somebody comes in and says, well, we have a new standard of care for something we're doing, here it is. And what happens in the meeting? Does everybody get really excited and say, oh wow, I'm so glad to get that, that's really going to be helpful, right? Or do they say, well, they don't really understand how we do it here, or do they, right? So the reality is it's standards plus local knowledge of adaptation. Both of those together are much more powerful than either separately. So local adaptation says, yes, we have to make change. We have to understand what the core change is. What's the hard center, as they say in implementation science? And what's the adaptable periphery, the things that we might change in our local environment because of our resources, including our staff, because of the kinds of patients we have and so forth. So think about this. And the experience and voice of patients, obviously, very important as you think about adapting changes. So one example is, again, from Sunnybrook, building a sustainable process, and that's quite a flow chart, integrating the patient voice to make sure that the changes we want to make are realistic in terms of the patients that we're seeing. So those are the 7 issues around sustaining and spreading improvement. They're easily adaptable to any setting, inpatient, outpatient, acute care, public health. So I urge you to think about this as you go about your current projects and you think about new projects. And our evaluation that we did of ideas, the first 3 years, went around and looked at posters, much like the ones you have here today, and said, so, are these issues really prominent in people's discussion about success? And you can see from this that, yes, it's about creating a culture and environment with support from leadership and resources to make a difference. So that's the agenda, right? Is not only thinking about what you've accomplished in the last 6 months, but thinking about, now how do I build upon this in terms of my project? And also, how do I build upon this in terms of the knowledge and skills that I want to develop? And we're fortunate to have a variety of resources, many of them available at little or no cost online, from HQO, from IHI, from the Health Foundation in the UK, and many others. And sometimes there's a small charge in this, but often if you come through and you ask people about access, and you're in a situation where you don't have the resources to do that, there's mechanisms to get there. So think about that. Think about what you've learned and then what you'd like to learn. What's the next step in your journey moving forward? And I wish you all great success in your work. So any comments or questions?
And again, just a reminder to use the mic so everybody can hear, both in the room and people watching from afar. Going once, going twice. Jacob?
Hi, thanks, Russ. That was great. My name is Jacob. I'm one of the statistical coaches from IACES.
Great.
And part-time photographer.
Great.
I was struck by the way you present the highly adaptable change as benefits beyond the patient. Because usually when we help teams set up their projects, we're saying your patient-oriented measure is your outcome, and effects on workload are a balancing measure. We don't want that to get worse. Would you recommend ever framing the workload measure as a second outcome that you're also trying to improve? So you're trying to make things easier and better at the same time, and change the way that's set up?
Yeah, that's a very good question, Jason. Thank you for that. So I actually think it depends on the situation, right? In organizations that have a strong quality culture already developed, you can go right to the patient outcome. But in places, and it's many places right now, where there's a lot of stress in the workplace and people are feeling overburdened, you recognize that if you say, and we're also tracking the impact on staffing, right? If you're working in an emergency department right now, the last thing you want is somebody to come along and say, I have a great project for you, right? So that's, you have to be sensitive to that. That's the reality in which you work. You have to understand the context in which you're trying to do that work and what drives people right now. People are open sometimes, not always, but open sometimes to short-term additions to their workload if you have a compelling vision about what it looks like at the other end, right? So that's the other piece on this. But it's being very aware that although everybody's there because they want to do the best for the patients and clients they see, the reality is they also want to go home and have a life at the end of the day, right? And we need to recognize that, I think, moving forward.
You touched on a piece saying that we now probably know more about QI work than our employers, potentially.
Yes, yeah.
And I think that's 100% true. So going forward, now that we have all this great knowledge and tools, how do we go in and take that and use it? Because now I see these changes being done from a hierarchy down, and they're not successful. And we've got all these great tools to build it up and make it successful. How do you break into that? Because there is a huge gap, especially in smaller.
There is a gap,
healthcare.
and we realized that early on, and that's why we created this executive sponsor stream of ideas to reach out to the people who are most directly connected to the projects. And that's been reasonably successful. We don't get all the executive sponsors, and we don't get their attention all the time, right? But let me tell you, organizations that have strong executive sponsors pave the route. Everybody else has their machetes out, and they're cutting through the thicket, right? And the people with executive sponsors discover there's already a path, right? We just need to go down the path. And so how do you make that connection for people? Well, it's finding somebody in your organization who sees this, who understands what it is you're talking about, and then using them, if they're in the leadership team to make a difference. It's not easy, right? And actually, as we're thinking about what the next iteration of ideas is, we're saying, we need a leadership agenda on this. We need to address senior leaders and their understanding of this as a strategy to improve care. There are some, and there are places that you can go in Ontario and elsewhere, but it's sadly not as far. So my only suggestion at this point is to find somebody who can help you make that conversation, right? And who can go forward and say, you know what, we could do this by fiat, but if you really want it to work, let's get a team together and figure out how to design this in a way that fits in with existing practice, the needs of the patient, right? And takes into account the additional costs that might be there in the short run. But, quick fixes tend to be undone, and people know that. So you have to give them an argument that they understand.
Thank you, Ross.
Okay, thank you.
All right, we're going to take a quick 180 second, not even, 120 seconds to bring down the walls, and then we'll start the presentations. So whoever's in charge of pushing the button, come on down.
Okay, so without further ado, we'll get started. A collaborative effort to decrease aggressive behaviors in rehabilitation participants with acquired brain injuries. Most number of words in a project title winner. Naomi, Nora, John, Stephen, and Carl. I just remind you that you all come up to the podium even if you're not all speaking. And away you go.
Thank you, everybody. It's been a fun journey. Our project was called a collaborative effort to decrease the number of aggressive behavior incidents. And we wanted to focus on this project because the incidents of abusive and aggressive behavior from patients with an acquired brain injury constitute over 70% of this type of incident in our 3 hospitals. It is disturbing to patients, families, and staff. When we started, we hoped to have had the following impact on patients who would benefit from being in a calmer place by having less agitation. Families who would have improved satisfaction with the care and learn to manage the behavior of their loved one. And staff who we expect to have better employee satisfaction and morale with fewer injuries reported and fewer sick days.
Our theory was that the rate of aggressive behaviors among inpatient adults with brain injuries is amenable to change to a reduced rate that's sustainable. That led to our aim statement, which is to reduce the rate of aggressive responses by adults with acquired brain injury who are admitted to the neurobehavioral units at West Park Healthcare in Toronto, Hamilton Health Sciences, and at the Parkwood Institute at London Health Sciences, London Healthcare. That is to reduce the base rate by 30% by May 30th this year. To understand factors related to aggressive behavior in our context, we use the following diagnostic tools. First, a consensus driver diagram. Second, requests to staff for their anonymous ideas about causes and treatments of aggressive behavior. And third, asking staff to vote anonymously on the most important causes of aggressive behavior. Staff participation in the latter 2 methods was encouraged by lottery draws. We found that a significant percentage of staff participated.
So we were successful in having staff from a number of different disciplines and across the different sites participate in the survey. And what was particularly useful for us was the Pareto diagram and developing ideas about what we should be doing next. For us, the number of ideas that contributed to the 80% were quite numerous and often quite equal and it forced us to take a stand back and think, is there some more central idea that we need to be addressing? And in fact, we thought about the idea of having personal control, improving choice-making, and the like as being perhaps ways to help address some of the problems for folks with the aggressive issue. As a next step, we thought, of course, as Dr. Bailey had mentioned, this idea is not new to us. This is an idea that's recognized in other neurological groups, so we felt good about that issue. We went on then to do some dry runs or trials, where one of the members of our team developed a scoring sheet, and we had people try with a patient either a simulated activity or an actual activity, and then rate how much choice making was involved in that completion of that activity. And while certainly that was there, we saw that there was actually room to improve and thought that this would be a reasonable effort to continue going forward.
So right from the start of the project, we recognized the importance of gaining different perspectives. So we engaged frontline staff as well as patients and families. And patients and families were interviewed to gain their, to identify the underlying causes of aggressive behaviors from their perspectives. And we found that the result was similar to what the frontline staff had identified. And through the dot voting system that was completed by staff, one of the major causes that was identified was the perceived lack of control by the patient. So our focus was on addressing that. And the change idea that we selected was something called choice-making activity. And basically what that means is that the frontline staff were given a behavioral task list or a script to communicate choice options to the client. And the idea behind that is that it will give the client a sense of control of their environment. So frontline staff engage the patient in simple activities that involve the use of tools that many of you will be familiar with, such as Tinker Toys, Lego bricks, and Lincoln Log. And some of these activities had been associated with refusers or aggressive behaviors. So we collected data and refined, evaluated, and went through different PDSA cycles. And so our intention is to spread the change idea on a broader scale, which Carl will talk about later on. But before I pass it on to him, I just want to talk about one of the great insights that the team gained from this experience is that during one of the PDSA cycles, an initial result was that frontline staff completed half of the tasks that were given to them on this behavioral task list. However, they did not engage the patient in the choice options. So that forced us to, consider the issue of burnout. And we wondered if, due to burnout, they were not receptive to a new idea, to the introduction of a new idea, or even open to, getting trained on a new skill. And should we be addressing burnout first? I'll now pass it over to Carl.
It is an interesting notion on burnout, as you can imagine, being hit or slapped or done something to day in and day out. It will not increase your overall satisfaction of your day. So you can just imagine how it is to work in these places. So our next steps, what we are planning to do with all the data that we have collected from the stakeholders, is to expand our interventions. Now, we've identified behavioral intervention strategies that we can use from best evidence or from evidence-based practices of how to acquire better outcomes. The goal now is to think both big and small. So how can we generalize this to all of our provincial sites? Now, one of the things that we're also embarking on is a continued collaboration between the sites. Now, as you can imagine, a lot of effort goes into creating change ideas in each location. We have the quality and really the being lucky of all of us being at the same time now in this project together. That means that we are able to engage in these activities together and have a much greater impact. So some of the ideas that we have is to reinvent or revigorate a group called OPEN, which is an organization of neurobehavioral programs in Ontario. So it's been dormant for a few years, so we want to start that up again. So there are a lot of next steps, but one of the bigger ones is to focus on the improvement of choice making within each facility. Now, our biggest challenges, well, there are a lot of big challenges with a task like this or a project like this that is across many different hospitals. You can just imagine one change idea within one facility requires a lot of work. Now multiply that with 3, and you'll probably get what I'm talking about. Now, one of the things that I noticed in my location specifically is regarding the time that staff have each within the program. So some are casual, some are part-time, some are full-time. Getting their input is quite hard, and that's something that needs to be thought about when you're creating these projects. And since I'm running out of time and I'm long-winded, I want to go to the last one, which is our advice for everyone else, anyone starting, is just think small and just start by starting.
Excellent, thank you. At the risk of being heard in the other room, I'm not going to turn my microphone on. What are you curious about? Comments or questions? Would you ask you to use your microphones? And panelists, I think you have to maybe get something to turn yours on. I'm not sure. Rochelle, go ahead.
So it sounds interesting that you almost have a project inside of a project with this question of burnout, and is burnout the driver for staff not engaging in the behavior you'd hope them to do with this patient choice? It would be maybe interesting to look at that. Is it burnout, or perhaps is it culture, or is it belief in the patient's capabilities? And I just wonder if you're considering understanding the idea of burnout, or what's driving that sort of resistance.
So, funny enough, I'm doing another research project where I was able to survey roughly 15 or 16 acquired brain injury rehabilitation sites, and it's quite staggering when you take the data. So we used MassLock, and we collected 150 or 160 responses. And there's a noticeable difference between individuals that work in a neurobehavioral site and those that work in a traditional stream API site. Although everybody experiences challenging behavior, the burnout is significantly higher in some of these locations. So yes, it is a problem.
Yeah, thanks.
What else are you curious about? See, please.
So you explained really well how you uncovered the causes, and I give you a big up for engaging the families in finding out the causes. But can you explain to me a bit about how you're developing or how you're deciding on solutions? Expand on that a bit.
So the variety of causes, there were 11 that were.
Can you just go a little closer to the mic, just
Oh,
so we can
sure.
hear on the live cast?
Yeah. We were able to condense 11 distinct causes for aggressive behavior and align them with known solutions. Because the causes, like Dr. Orenchuk described, were multiple, we had to aggregate some of them, 4 of them in fact, to account for a significant percentage in the Pareto chart. And when we did that, it aligned well with empirically validated, well-established change methods, choice-making routines that have been validated in empirical studies with groups that are quite similar to those with whom we work.
Thank you. Time for one quick one. Anybody got one quick one? All right, yeah, Leslie. Don't make it hard, Leslie. Quick one. Quick one, Leslie.
Actually, it's not data related, but I was just curious when you were talking about expanding your intervention to the multiple sites, if you anticipated any challenges based on the makeup of those sites compared to the one you've implemented your change idea in already.
So the question, the question is issues with implementing across sites. Now, the answer to that is the only way in order for us to counter that could come up is for us to work together and go to each other's locations, and that we are doing. So, you know, fun thing that comes out of this is I get to travel more, which is nice. But yes, you are right. In order for us to be able to make better choices, we have to be able to see what each and every one is doing. So that's exactly what we're doing.
Excellent.
Thinking about having
You have to use the microphone, or they can't hear you. And then I'm going to move you along.
We're also thinking about developing skill champions at each site that may in fact collaborate with each other so that we hand it off and let the folks work it out in the ways that they see best fit.
Congratulations, thank you. So this is the all teach, all learn part. So remember the flow. Over you go to Agnes. Next team, Pearlie comes up behind me. Over you go to Agnes to get your certificates and your photo. Smile nicely for the camera. Go all the way, oh, you go all the way over. No, everybody together. Yeah. It's a group picture, it's not an individual. We'll be here till 5 o'clock, we take individuals. If you want to be here till 5 o'clock. So a really nice segue, because this team ended up talking a bit about burnout, and we don't plan these things, but serendipitously they happen. Our next presentation is Enhancing Joy in Work for Personal Support Workers in Long-Term Care. So you're going to hear a little bit more about burnout. So you guys can come get yourselves situated. And as soon as the paparazzi are done, and apparently you can't hear me in the other room now, so that's good.
Hello, I'm Andrea, and this is Lacey, Kelly, and Rebecca. And our project is called Enhancing Joy in Work for PSWs in Long-Term Care. And we really wanted to focus on this topic because burnout is highly prevalent in the long-term care sector, especially for personal support workers who have their own set of unique challenges and are the largest workforce group in long-term care. And burnout in PSWs has been shown in literature to be a contributor to resident abuse incidents. And resident abuse prevention is a fairly new area of quality improvement focus at Pearlie-Rideau. And burnout also aggravates the health human resources shortage that the health system is facing. Staff burnout often leads to the provision of substandard care, early retirements, and lower levels of staff engagement, which create challenges for the recruitment and retention of quality PSW providers. So while Pearlie-Rideau did not specifically measure burnout prior to this project, indicators like the Employee Engagement Survey and PSW monthly absenteeism rates indicated that burnout was likely prevalent. So what we ultimately desired was for our PSWs to feel less burned out and to experience more joy at work, engaging and connecting with residents to provide the best possible care for them. So that led to our aim statement, which was, by January 31st, 2019, self-reported emotional exhaustion levels for the PSWs on the 2 target units will decrease by 15%, as measured by the Maslach Burnout Inventory. So we chose to focus on emotional exhaustion, as this tends to be one of the more concrete conceptualizations of burnout, as well as because the single unit, the single item burnout measure question that we used for weekly data collection was based off of the emotional exhaustion subscale of the Maslach Burnout Inventory. I'm going to pass it over to Lacey.
Thanks, Andrea. In order to understand more about PSW burnout, we started with a fishbone diagram in our first PSW focus group. We asked the participants to identify reasons that's currently contributing to their burnout. We also did a dotmocracy exercise. We gave them 3 dots and asked them to choose the top 3 issues they would like to list as the top items. Then Alice helped us to organize the results into a Pareto chart. And what we found is that almost all the top items are associated with either either teamwork or team dynamic. And that's the reason why these are the two things that's very dominant in our driver diagram as secondary drivers. When generating change ideas, we did extensive literature review and we consulted with our subject experts. We envisioned our change idea to help the team to work better together and also to deal with the challenges and the stress every day as a team in order to prevent and decrease burnout. We landed on the change idea to implement a standardized approach to shift report on the target units. And Kelly is going to tell you a bit more about that in a few seconds. Our team had challenges when explaining to staff on the target units while we are working on shift report when trying to reduce PSW burnout. We find it very hard to make the connection about a very technical solution to such an adaptive change we're trying to achieve. However, because of our change idea is fairly technical, we were able to apply the QI methodologies we learned through the IDEAS program to a greater extent. Also, this change idea addresses multiple secondary drivers in our driver diagram. We hosted another focus group consists of RPNs and PSWs to co-design the new structure of shift report to ensuring the process is actionable and meaningful to achieve better teamwork. Some of the participants are from the target units to ensure staff buy-in. Some of the participants are identified because of their strengths of hosting shift report in a great team approach. We also collected baseline data for both of the full mass stock burnout inventory as well as the single item measure. We had great participation rate for the MBI tool. About 80% of the PSWs on the target units have participated. Our single item burnout measure baselines collected during the focus group that we hosted with 16 PSWs from all 3 shifts on 2 target units. Now I'm going to hand it over to Kelly.
So to begin to address some of the contributing barriers to joy in work, the team developed a change idea that would utilize the present time that all staff meet prior to their shift, being shift report. By optimizing this protected time, we hope to enhance team dynamics and encourage staff to prepare for their day as a team. The shift report agenda was developed with support from frontline staff through focus groups and PDSAs. This tool ensures that only crucial information is reviewed, allowing more time for discussions that would enhance interdisciplinary problem solving and team building opportunities. The team was able to complete 3 PDSAs, which included the early developments of the shift report agenda. Some of the feedback we received from staff were that the tool was going to be helpful in determining what information is crucial, and if implemented appropriately, could possibly improve the teamwork dynamics on their units. Staff really appreciated the acknowledgement and orientation of new staff members on the units as well. There were also some excellent recommendations to improve the tool. For example, restructuring the tool to fit into a 1-page document, which has since been completed. In terms of weekly data collection, we altered between our pilot units with the single item burnout measure, which consisted of the question, overall, based on your definition of burnout, how would you rate your level of burnout? We plotted out the results of the single item burnout on a weekly basis to compare results pre-intervention and post-intervention, December 28th, 2018 onwards. No notable decreases in the single item burnout measure were observed. We also re-administered the more comprehensive mass burnout inventory, which was conducted with PSWs on our pilot units in September 2018 pre-intervention and January 2019 post-intervention. Scores in the emotional exhaustion subscales showed a notable increase in score post-intervention, meaning a higher level of emotional exhaustion was felt. It is possible that there are factors outside of the change idea implementation that influence the increase in the emotional exhaustion scales that should be explored further. Such factors could include the post-holiday time period, illnesses, poor weather, and changes in staffing on the units. Post-intervention, there was also a slight increase in the depersonalization scores and a slight increase in the personal accomplishment scores. That's over to Brenda.
So as Kelly mentioned, we actually saw our emotional exhaustion scores increase rather than decrease post-intervention, which is interesting, but leads us to believe that our next steps include further PDSAs on our pilot units and continuing to measure to see and to look at some of the other underlying factors that might be at play to see whether our intervention is actually having a positive correlation to burnout and really making sure that what we're doing is the right thing. We're considering sustainability as well when we're planning our next steps. We went through the NHS Sustainability Guide, and we found that while employee engagement and the level of involvement employees had was a positive contributor to sustainability, we don't currently have systems in place to monitor outcomes on an ongoing basis after this project finishes. So that's one of the areas we have to improve from a sustainability perspective. As Lacey mentioned, we found it challenging to apply a technical solution to an adaptive change and to draw those linkages between the issue of burnout and then the solution of a shift report by way of teamwork. So we had to be very explicit when we were speaking to different audiences about that linkage. Of course, it was also difficult to demonstrate outcomes because teamwork as well as burnout are very multifaceted issues. Our advice for anyone starting on a QI journey is to leverage diagnostic tools to question their assumptions and to really validate that the change ideas being considered are going to result in actually addressing the root causes. We certainly ended up somewhere different than we might have anticipated if we hadn't done the focus groups that we did. We engage staff actively in root cause analysis as well as in designing the solution, but we didn't involve them as closely in actually generating different change ideas, so we see that as well as something that we would do differently if we were to start this project all over again. We're really excited to see where this project takes our organization. We'd like to thank our executive sponsors at the Pearly Rito who may be watching. We'd also like to thank the IDEAS faculty and program, as well as Alice for being a wonderful coach and for her invaluable guidance through this journey. Thank you.
Thank you, and you just gave everybody in the room a breath of relief, because it's okay to have not achieved what you thought you were going to achieve in the time frame, right? FAIL stands for first attempt in learning. That's all it is. So fantastic, and thank you for sharing that. What are you curious about?
I'll ask my question. I was really interested in your project because at the Community Health Center in Guelph, we have worked really, really hard on provider engagement, that quadruple aim of provider experience and really understanding the improvement of care. I wondered if you measured, although you didn't see an improvement in burnout, did you ask the participants about the staff report whether or not that actually improved teamwork? You know, maybe the burnout will be a more longitudinal change that you will see over time and not in the expedited time of IDEAS, but perhaps longer term. But did you hear any either anecdotal or measured change on the actual experience of teamwork amongst the group?
So that's not something we explicitly looked at. What we did do is we administered an evaluation after we provided training to personal support workers and RPNs on the unit in the new shift report tool to ask whether they believed that this new tool would improve or could improve teamwork if consistently applied across the units. And we received very positive feedback from that tool. We haven't taken it to the step of actually going back now and asking whether teamwork has improved, but that's certainly something that can be considered in our next round of PDSAs. Anything else?
And to further add to that, the same evaluation, we included some things through the literature review. We learned that psychological safety is a very big contributor to teamwork. And Andrea has done amazing research in finding those symptoms of psychological safety within the team. So as part of the observation, we as the trainers will see how many behaviors that's contributing positively and negatively to psychological safety has occurred during the shift report.
So you talked about one of your learnings being engaging staff in potentially development of the solutions that you came up with. I was wondering if you considered at all patients or families' contribution to joy of the staff and how you might consider including them in either understanding root causes or developing a solution.
Okay, give it a try. At the Pearly Rideau, we actually have very, very strong culture for involving our residents and families in every QI initiatives that we do. And for this one, it's a bit different. As Andrew has explained, it fits under a bigger umbrella of abuse prevention. That is a priority at the Pearly Rideau. For other parts under abuse prevention, we have extensive involvement in family advisors and patient advisors. And this one being very staff related and also a very time constrained project, we did not have the opportunity to engage residents and families extensively. But it's definitely something we have heard during the PSW focus groups that we feel it'd be providing a lot of opportunities in communicating and collaborating with residents and families.
Excellent, thank you. So watch the flow, watch and learn. Over we go. Excellent. And as they get their certificates and the paparazzi swoop in, we'll welcome the small but mighty team of Alyssa and Kathy, Reducing Preventing Consumer Harm in Independent Living Waterloo Region's Attendance Service Program. Sorry, I did the acronym for you. And we'll just let them get their photo and we'll be all good. You'll need to line up in the order in which Agnes has the certificates. Just kidding. Just kidding. All right, ladies, you're on.
Hi, everybody. So our project was called... Better? Awesome. Our project was called Reducing and Preventing Harm in ILCWR's Attendance Service Programs with a specific focus on falls. We wanted to focus on this project because in our organization, we felt that there were preventable consumer falls as a lack of policies, procedures, and guidelines. Zero harm is one of our key performance indicators in our organization, with falls being the highest reason for consumer harm. When we started our project and this journey, we hoped to reduce consumer falls by 50% in 5 months. Oh boy, were we shooting for the stars there. After our first learning session, we quickly realized that this was too high. The bar was much too high for the time we had. Thus, our aim statement was changed to reduce falls by 20% by March 31st, 2019. Along the way, we started talking to our attendants to understand why our consumers were falling. To help us understand what was going on and why our consumers were falling, we completed process maps, a cause and effect diagram, and a driver diagram. After completing our driver diagram, our aim changed to 50% of ILCWR's consumers will have a completed falls risk assessment and integrated care plan by March 31st, 2019. As the word spread, we started to see the increase in the amount of consumer falls that were being reported. We started to question what was going on. Was this a random event? Were we making things worse? As we started to dive into our data, we started to realize attendants were reporting more falls based on their increased understanding of what a consumer fall was. The most helpful tool was the driver diagram and the cause and effect diagram. These two tools helped us focus on one task instead of everything all at once. Based on our baseline data and diagnostic tools, we trialed the Morse Fall scale to classify our consumers into categories. Currently, 64% of our consumers sit in a low falls risk category, 12% sit at moderate falls risk, and 22% of our consumers sit at high falls risk. From there, we developed process maps for each level of falls risk and a standard around follow-up time. At one of our assisted living sites, we completed a PDSA in which the lead attendant was asking a standard set of questions after being informed of a consumer fall at the assisted living site. This resulted in more timely follow-up and a better understanding of why these two particular consumers were falling. We are now hoping to spread that knowledge out into our geographic areas. Our reported data has ebbed and flowed over the last several months. Unfortunately, recently, we've seen a decrease in the amount of reporting across the board for consumer harm, not only specifically just falls. Our next steps are continuing to make changes to our follow-up and reporting through Alaya Care, which is our new Cadillac of databases, which is coming in a month, to continuing to gather data through the use of technology. Our biggest challenge was finding and creating the space for this project and getting buy-in from a bigger team, from our coworkers and from attendants. We're starting to feel that from some of the other knowledge that we've gained from this ideas program and some of the speeches that we've heard today and in past, that there may be an impact of burnout on our attendants and our coworkers. So we're now going to want to start to look at that to see how we can improve that. Our biggest piece of advice for anyone starting their QI journey is to celebrate the small wins and focus on the small wins. You know, you're not going to change the world in a matter of 5 months, but what are those small tests of change that can have the greatest impact in the smallest amount of time? Thank you.
Excellent. Thank you, Alyssa. Sounds like we need to run a burnout cohort. What are you curious about? Lots of learning. Francine, please.
This is going to sound like a strange question, but what was your driver for deciding that reducing falls was your topic?
So we collect data, zero harm being one of our key performance indicators. So we collect data as what we've defined as consumer zero harm. Our 80% was consumer falls.
It's not a bad question at all, Francine. That's a fantastic question. Thank you.
You talked about wanting to celebrate your small wins, and sounds like there was quite a few challenges that you faced along the way. What was one of your greatest small wins that you were able to celebrate?
I think just having the attendant at one of our assisted living sites follow up at the time of being informed of the fall. I know myself and Kathy, as in supervisor roles, it can be very difficult to follow up with our consumers in a timely fashion, and you're not getting real-time data as to why that consumer has fallen. They may forget, or they may not even understand themselves why they have fallen. So with the attendant asking that, you know, at point of care follow-up, it's a better well-rounded follow-up to understand what impacts were in play in terms of environment, materials, things like that.
Thank you. Excellent. What else are you curious about? You're curious. Come on, I know you are. You might want to pick this team's brain over lunch. Oh, go ahead, Leslie. Yeah. This won't be a hard one. She's been warned.
It's okay.
No, I got caught writing down the numbers of when you were looking into the low, moderate, and high risk. And I wonder if that would be something that you'll continue to track, just to see if there's changes across those scales, which then would have an impact on maybe the reporting.
Yeah, so we will continue to still track what level of fall risk our consumers fall into. In fact, it's kind of an ever-changing percentage for each category, because as soon as a consumer has more than one fall, they automatically flip over into a different falls category. So I anticipate that we'll see our low fall risk category decrease, and moderate and high percentages, unfortunately, will increase.
Do we have time?
Yeah, sure. Yeah, go ahead, Heidi.
Just along that note, I'm just wondering if you're also considering maybe near falls.
Yes. So we're working from the WHO definition of what a fall is, and that would indicate that they are falling from one surface to another. So that could even be in a transfer, that the sling wasn't hooked onto the Hoyer properly and the consumer fell, a foot. That's still defined as a fall.
Excellent. Thank you. Watch the flow, live and learn. Very good. And we're halfway through our morning program, so I'm just going to invite you all to stand up for a minute just as the next group comes up. Take a little tour around your chair. Just, shake out whatever needs shaking out that you can do in public. Give yourself a little stretch. A little hug. There's some hugging allowed too. Yes, hugging is good. Excellent. All right, and so we now have our, you guys might win the award for coming from the farthest. You can sit down again, by the way. Never let people start talking. You can sit down again, by the way. So we want to welcome up the Creators Care, First Nation Palliative Care and End-of-Life Service Development, Edith, Heidi, and Natalie. Take it away.
Thank you. Ani, good morning, everybody. Our project is called Increasing Goals of Care and Advanced Care Planning Discussions. And we chose to focus on this project because it contributes to the ongoing development of our Creators Care End-of-Life Service to improve and advance high-quality palliative care for our First Nation communities. Anecdotally, we observed our First Nation clients reaching their end of life without having advanced care plans in place, making it quite challenging for our healthcare providers to and their families to know their wishes and to follow through on those wishes. Part of the work that we have done is to get the teachings around end of life. Death and dying is something that we don't want to talk about. Willard Pine, one of our Senior Patient Advisory Council members, shared that the end-of-life journey is something that we need to embrace and to celebrate. We are going back to the Creator. In his teachings, he talked about the Creator's care. It's that love that's wrapped around you at your end of life. He told us we have to get back to the teachings to prepare people for that journey. It's supposed to be a beautiful journey. And when he works with people, he tells them that they are in the hands of Creator's care. Therefore, our palliative care model was named Creator's Care.
Thank you. When we started our QI project, we hoped to engage our multidisciplinary care teams to support our integrated palliative care approach to care. This approach incorporates relationship-based, culturally safe goals of care, advanced care planning, conversations with palliative clients and their families. We began with the assumption that our healthcare providers were not comfortable initiating these difficult conversations with their clients who have been diagnosed with a life-threatening illness. And that led to our AIM statement, which is by March 31st, 2019, 90% of our healthcare providers will report being comfortable with having goals of care and advanced care planning conversations. We found the driver diagram a useful tool to guide our QI project to achieve our AIM statement. It kept us focused and with the scope of this smaller project within the larger initiative of Creators Care. We engaged our healthcare providers in our diagnostic journey, first through a staff survey to gather baseline data to help us understand the level of comfort with advanced care planning conversations. It was interesting to note that some of our healthcare providers indicated that they were very comfortable with having these conversations, but then also responded that they had never had these conversations. So that really was something for us to try and figure out. So we then completed a face-to-face fishbone exercise to determine the root causes to help us understand more about what was contributing to our problem. Through this exercise, it did show that our assumptions were correct and that staff were uncomfortable, our clients were uncomfortable, and staff felt that it was someone else's role. A lack of training and resources was also a strong contributing factor.
It's nice and low. I'm used to it being really, really high. So based on the diagnostics that we've completed and our understanding of our baseline data that we had, we decided to actually begin our improvement by actually providing all staff with First Nations LEAP training, which is actually a culturally adapted version of the Learning Essential Approaches to Palliative Care, if anybody's ever taken that training. We have completed one training session to date with an interdisciplinary mix of our health service providers, very well received, and we had many participants afterwards that expressed their interest in becoming more involved in further development of our Creators Care model. So in terms of our next steps, we need to complete our LEAP training with the remaining staff. Then we plan to bring together an interdisciplinary team to actually create a clinical pathway for having those goals of care and advanced care planning discussions. And we also need to develop resources for our providers, our clients, and their families. Our next step is then to actually complete our post-survey with our staff to see what their comfort level is with having these conversations, to see if we came near our 90% AIM statement. We're really hopeful. And then finally, we do plan to establish a process to actually monitor our provider performance in the EMR. Our biggest challenge, well, that was bringing our staff together to actually complete the root cause exercise. Due to our vast geography and the nature of our services, it's very difficult to bring everybody together to do that face-to-face fishbone exercise. So this caused a bit of a delay for us in actually getting some baseline data and limiting our ability to use some of the great tools that we learned about in our IDEAS training. So our advice for those starting on a QI journey, as we did, is to try to be that further along so that you actually have that nice baseline data to start with, because we always felt like we were making a lot of assumptions in the beginning. It's better to take your time and ensure a great end result than to rush through the QI journey. Thank you, Alice, for reminding of us that so many times. And we really look forward to moving our current QI project further. We're certainly not done by any means, and we really want to engage our multidisciplinary teams to use the IDEAS concepts for future quality improvement endeavors. So on behalf of Edith, Natalie, and I really want to thank the IDEAS team, the large group, as well as our QI advisor, Alice. Thank you so much. And our executive sponsor, Gloria, who I think is watching today, Gloria Daybutch with Mum Wessing North Shore Community Health Services Incorporated, Joanna Vauture with Cancer Care Ontario, and of course our fellow Cohort 16 IDEAS teams. Thank you so much.
Excellent. Thank you, Heidi. And you will call us on March 31st to tell us your results.
Definitely.
Yes, yes. Excellent. What are you curious about? Francine, please, yeah.
So I loved the quote you started off with that one of your patient advisors gave you, that it's going back to the creator. I want to know how that statement impacted you either personally or specifically in relation to how you did your QI project.
I think when we got the teachings from Willard, it was a turning point for the development of our palliative care program, because it did ground us in the work that we had to do. So the QI project is only a portion of the work that has to be done with developing our palliative care program, but it's essential to have this completed because we need to engage the full staff, the multidisciplinary team within our organization to be able to deliver the palliative program. So it's all of our responsibility to have those conversations. So we knew that that was going to be the foundation to continuing on with the development of our palliative care program, because if we're not having those conversations and goals of care discussions, how are we going to be able to deliver a service to meet the needs of the individual? So it was absolutely a foundational, and going back to the teaching keeps us grounded in the work that we need to do. So,
Yeah, Rochelle, go ahead.
Did you find that there was a bit of a mix between the comfort of having the conversation about end of life, which is understandably difficult, and then also perhaps a limited understanding of the teachings and the worldview, and sort of how did you, if so, I see you all nodding, how did you sort of address those sort of multi-pronged issues together with your team?
So, well, definitely that came out loud and clear. So it was interesting, when we did our fishbone exercises, we did two. We did one with our Senior Patient Advisory Council alone, and we didn't share those results with our healthcare provider team. But it was interesting how the teachings were identified with our health service providers as well, but it came out loud and clear with our Senior Patient Advisory Council that we really needed to incorporate that piece in whatever kind of training or wherever we went from here. So our starting point was to look at the modified LEAP program that has been modified to address, hopefully a little bit, I haven't taken it yet. I just admitted that, sorry. But we're hoping that at least there'll be a little bit of cultural teachings there, but in our pathways, especially when we start talking about how we're having those goals of care and advanced care planning discussions, that's going to be a huge element in our training process, for sure.
Awesome.
Thanks for asking that. Yes.
I want to add as well that, like, through the teachings, culturally, death is not a final place. It's a journey on to another place. So when we are having our conversations, we have to end our training with people. We have to incorporate that. because a lot of the traditional ways of, like traditional as in mainstream ways of speaking to people about advanced care planning and goals of care is usually, to talk about that final resting place and stuff like that. So we have to remember and incorporate that in our culture. Death is not that final resting place, but rather a journey.
Awesome. Thank you.
I was going to say too, the journey doesn't even end at that point either. It's the aftercare, even for the families as well. That's another thing that I think came out pretty loud and clear in our engagement sessions as well. So it doesn't end with that final piece of that journey, but for the rest of the family left behind, we need to keep them within the Creator's Care model as well.
Excellent. Thank you very much, ladies. You can flow to the side. And we welcome up the Skin to Skin post C-section, Health Sciences North Baby Friendly, Doris, Krista, Carolyn, Leanne, and Julie. We'll just give them a minute to get their photos. I was organized up there though, if you like. Adjust the mic if you want to. We have some guests that have arrived to hear you. Yeah, when you're ready.
Good morning, everyone. We did have to change our presentation a little bit on the fly. 2 of our members were bumped off our flight this morning. We were originally going to start with a skit. We have props and everything, but we're going to, instead I'm going to describe the skit to you at the beginning and at the end, so you can get a better idea of what we were going to do. So our project was doing skin to skin in the OR and is part of the Baby Friendly Initiative. So if you can imagine that you're a mother, you're about to give birth, you're in the C-section, you're having a C-section, you're in the OR, you're on an operating table, your arms are to the side, the poles are kind of on either side of you and there's a drape. You can't see anything. Most people are talking around you. No one's really talking to you. The baby's born, they hand off the baby to a respiratory therapist. Still out of your line of vision. You may hear crying, you may hear nothing. They're looking at the baby. Sometimes we invite the dad over to come see the baby. In a dramatized skit, we were actually not going to address the mom at all and talk about the baby and not address the mom and not tell her the gender and not tell her if anything is okay. And mom was going to get more increasingly upset and anxious. So we were going to say that is a dramatized version of what we are currently doing. So now we'll introduce our project.
So I do want to acknowledge Julie and Leanne, who couldn't be here because they're frontline staff and they're very significant and pivotal to our project. Our project was called Skin to Skin Post-Cesarean Section in the Operating Room. We were doing really well with skin to skin for vaginal births, but we were really leaving out a big portion of the population that are having cesarean sections. We wanted to focus on this project because Health Sciences North was stalled in their journey of getting the Baby Friendly Initiative designation. And this is a designation of the World Health Organization for best practice in maternal child care. The BFI strategy for Ontario wanted to support them in their goal and offered to fund our participation in ideas. Doing immediate skin-to-skin post-delivery, whether for vaginal or cesarean births, is one of the 10 steps to achieve the BFI designation, which was our big dot aim. Working on implementing this one step has brought light to other best practices, which are also being improved along the way. A highlight for me in working with this amazing team is that they have always focused on the patient experience and satisfaction, which has been pivotal in moving the project forward and also in bringing along those people that maybe are naysayers. When we focus on the patient and their best outcomes, it really is amazing the results that can happen.
By engaging and educating stakeholders to contribute in this project, we believe that we're able to achieve our goal with getting our BFI designation. Our theory is that we should be able to perform skin-to-skin with all deliveries. And this will have a significant benefit to the mothers and their newborns with transition and their outcomes. Wanting to ensure that we had success, we decided to start with a smaller subset of group of elective surgeries before going full spread. And that led to our aim statement of the percentage of skin-to-skin at HSN for all term deliveries born in hospital in the OR after an elective cesarean section increased to 50% by May 31st, 2019. The ideas curriculum and our advisors have really helped us in determining and give us an understanding of what our contributing problems were. With the fishbone, we were able to determine and identify root causes of any of the barriers that we may be facing, such as physical space in the operating room and staffing. The driver diagram also helped us to dive deeper into those barriers and formulate some of our change ideas that we've been working on. We completed PDSA cycles in November and in the OR, which led us to develop a tentative process and outline some roles and responsibilities and areas for improvement. Your turn. We have to take everyone else's spot.
So our baseline data show that we were already doing skin-to-skin in the OR about 11% of the time. However, we did notice that we have limitations within the data that we're able to obtain from our provincial database. So the way the question is worded in the provincial database, the timing of the skin-to-skin is not specific enough to identify if the skin-to-skin is being done in the OR or if it's being done in the recovery room. So therefore, we had to have additional documentation fields added to our electronic record in order to capture this level of detail. So that's been done now, and we are manually auditing this new electronic record for specific timing of skin-to-skin and elective cesareans. For sustainability of our project, we are going to continue to present this data collected at our BFI committee meeting as a standing item. So we originally thought that this was going to be a simple fix of education, policy development, and implementation. We now realize that engaging staff is a much bigger hurdle than we originally thought. So we're going to use patient satisfaction and emotional mapping surveys in the hope that we can understand the patient experience and get buy-in from stakeholders by sharing those experiences and that data with them. We have engaged patients by discussing the benefits of skin-to-skin post-cesarean section prior to their surgery. And after our PDSA, we were following up with that emotional mapping survey. These tests of change have resulted in engaging our stakeholders in role development as opposed to us dictating their role. So for example, in our first PDSA, we assumed the respiratory therapist who does the cesarean APGAR scores would prefer to do other duties that the circulating nurse would do, and that the circulating nurse would take care of the baby and place them on the mom. And in fact, they didn't like that, and they actually asked us to switch, and in our second PDSA, we had the roles go back to what they normally were, and that was actually more beneficial for everybody.
Our next steps is to identify champion stakeholders from different disciplines within the hospital, anesthesia, OB, nursing, frontline staff, in order to ensure that they are represented when we develop the policy and finalize it. We're really excited about the data collection for the emotional mapping survey from the patients. We really want to see what their current experience is like and how we can build off of that and improve our care for them and give them this opportunity. Our biggest challenges we are facing, which I think a lot of people have, is staffing, which again, I think there's a common theme of burnout and increased workloads. So we're hoping that with role reversals or role changes that we won't be impacting or increasing their workload at all. And our advice for anyone starting a QI journey is don't underestimate how seemingly small, straightforward change, how it has a huge impact on patients, families, whether hopefully it's a positive impact, but how a small change can make a big difference.
So in conclusion, we would like to do our last skit where I'm going to get you to now imagine what we are hoping is our future state. So now you're a mom in this, having an elective section, and you're in the OR, and as soon as your baby is born, the RT brings them to the warming table. They do a quick evaluation of that baby. Baby is stable. They bring the baby right over to mom, who's been consented. She knows what's going to happen. The support person knows what's going to happen, and they're going to place that baby immediately on the mom for skin to skin, and that's going to increase their bonding. That's going to be beneficial for physiological transition of both the mom and the newborn after a massive surgery and birth. And it's also going to increase our rates of exclusive breastfeeding and is overall going to give us a better patient and family experience. So that's our conclusion. We'd like to thank our executive sponsor from BFI Ontario, Linda Young, for allowing us to come to ideas, and our clinical manager, Lisa Grace, for attending and supporting us throughout this journey, and also Agnes for my constant emails to you about my data charts.
Thank you very much. Excellent. Excellent. I want to ask the first question. Which airline are we angry at today?
Air Canada.
Thank you. Always important to shame the airline. Comments or questions? What are you curious about? Gentlemen, what are you curious about?
I just want to start by saying that change in data collection is a small but huge, like, that's great. But I was also just wondering about buy-in of the team sitting in the OR. Is that something you're measuring, something you plan on measuring? Their buy-in on the practice itself?
One of the things that we did when we did our PDSAs is we involved them in the debrief and also talked to them about it beforehand. And it was amazing to me, not being part of the hospital, of how open they were to really looking at the different roles that they would, and impact that it would have, and really embracing it and looking to want to make the positive change. So to me, it was really encouraging. For some of them, there's big changes, but for others, it's just minor adjustments, and they seem to be really willing to do that and to talk to their partners about that as well.
Yeah, Michelle, go ahead.
When you talked about patient engagement and then working with the mom beforehand about the expectations, et cetera, how did you balance when it didn't work the way they expected? Because I can absolutely empathize with the confusion in the OR and sort of not knowing what to expect. But if I expect now, because you've told me that my baby's going to come to me and now they don't because of buy-in in the OR, like, did you have to manage any of those challenges where now you have an engaged and informed patient who now is disappointed?
When we did our PDSA, we actually had a patient who wanted a general anesthetic, didn't want to be awake, was so anxious, so nervous. And we got consent from her. She was willing to do this, and it worked out actually really quite well. But during the surgery, she only had, how long was it for? 15 minutes of skin to skin. I've never in my life seen somebody, well, I have because I do it all the time there, but seen somebody so elated and so happy, and the anxiety. I said, you haven't stopped smiling the whole time. What had happened was then she had chest pain. So she was getting this chest, she did have it, she was getting chest pain, and we had to take the baby off. But it was still, she didn't even think about the chest pain. All she thought about was a skin to skin. When it comes time to, when we educate the patients and discuss with them, there are inclusion criteria and exclusion criteria. And I think overall, when it comes to just the baby's transition, if they don't meet those rapid evaluation questions right at birth and they're unstable, I think that everyone and the parents would agree that the baby needs resuscitation. And then as soon as the baby is stable and then we can put the baby skin to skin, and it can be after. It doesn't have to be immediate, but we're trying to initially do that. And we know there's going to be one offset. Not everybody will have the opportunity to do skin to skin.
Great, thanks.
Excellent. Time for one more. Who else is curious? Yeah, go ahead. Agnes is there with the mic. She'll come to you.
Okay, thank you.
These are our baby-friendly initiative colleagues.
Yes. Well, congratulations, guys. We have done this in our hospital, and we know that it's not always easy. My question for you guys is, who do you think, or what do you think was your biggest obstacle? Without names, but maybe position.
I think our biggest obstacle is getting staff to want to do this change, which is why right now we are distributing a patient satisfaction survey with the emotional mapping. It's pretty hard to say you're not going to do something when you have clear data of your own patients saying this is something that they want.
And for getting them to, and for them to realize it's not about them, it is about the patient. It really truly is about the patient. So, and I think we're just, it's increasing my workload. It's making me do this. I'm gonna be late for my lunch. I'm not gonna be able to go to the bathroom. I'm gonna, these kind of things. Whereas this is more important for the baby for that transition and for the mother, for their outcomes also.
Excellent. Oh, go ahead, finish, yeah.
I just want to say that having a partnership with the hospital and the BFI strategy for Ontario, the benefit is that all of these learnings can now be spread to every hospital across Ontario. So it's a huge partnership initiative, and it's really a great win for everyone.
Excellent. Thank you very much. Follow the flow.
My son was born 6
And I think
years
we
ago.
have some entertainment coming forward. The Toronto Infant Hearing Program, Joanna, Evelyn, Leslie, Julia, and some friends.
Give me my baby. Yeah, give me my baby.
What's wrong with my baby that I don't get my baby?
Yeah, exactly.
Little props, depending on the prescription. All right, so our project title is a Family Transition Journey, and we are a team made up of 2 agencies. We have myself, Joanna Nickel, we have Leslie Way, and Evelyn Pepe from Toronto Infant Hearing Program with Toronto Public Health, and we have Julia Robinson with the Ministry of Education, Provincial and Demonstration Schools Branch. And we just like to do a very quick grateful thank you to Agnes, our QI advisor, and Linda Yapugian and Jeannie Leonard, our executive sponsors. So the clients that we are so grateful to be able to work with every day are children who are identified with permanent hearing loss and their families. And we would like to begin with a skit, just to show you a bit of a family's journey. So now we'll transport you to an audiology waiting room where we have 2 parents waiting.
I'm invisible.
Oh, hi. Oh, your child is behaving so well. Do you have any troubles keeping his hearing aids on? I'm having such trouble with my Emma. She keeps trying to take them off.
You know what? When Bobby was her age, we had problems with that too, but things are going okay now.
Well, things have gone a little bit better for us. Our audiologist and our home visiting teacher have been giving us lots of good advice, but I just can't wait till she's your son's age.
What? Home visiting teacher? What's that?
Well, we have a teacher of the deaf who comes to our home twice a month to offer us school readiness services. They have a whole curriculum. She's been giving us lots of great tips on activities, on how to play with Emma, to work on things like joint attentions, to support us with like early literacy skills. She's amazing.
Really? We don't have that at all. Is that through the infant hearing program?
Well, it's actually through the Provincial and Demonstration Schools Branch, and it's a resource services and outreach program. That's actually funded by the Ministry of Education. That's different from the infant hearing program. That's funded by a different ministry.
Okay, you know what? That Ministry of Ed part sounds familiar, but everything was just so overwhelming at the beginning when we got the permanent hearing loss identification. Maybe the audiologist told us about it. You know what? I don't even remember.
Well, it's actually our family support worker who connected us to the teacher. And then the teacher told us that the resource services is not just about home visiting program. We've been going to the play and learn centers recently. It's a great way to meet with other families and play together.
Wow, I can't believe we missed out on all these opportunities.
So as you can see from our scene that we just did there, we had a family that had been successfully transitioned to Provincial and Demonstration Schools Branch for its resource services and home visiting program. So we will refer to Provincial and Demonstration Schools Branch as PDSD from now on, and another family that hasn't been transitioned. We found that less than half of our Toronto IHP families have been successfully transitioned for these school readiness services. In our diagnostic journey, we found that we didn't have a standardized policy or procedure regarding this transition process. That meant that we had no clarity as to who was doing the transition, when the transition would occur,
and what information was provided when the offer was given to the family. And as a lead agency, we didn't know whether the offer was even given to the families at all. So for our project, our theory was that if we were to standardize and streamline the process of having the audiologist to offer the transition to PTSD at the first identification appointment, that would, all the eligible families will be given that offer, which will increase the transition rate. And ultimately what we want is that we want more IHP families to be able to receive this services, to receive support to get their child as ready as possible for school entry. So for our theory, for our project, our theory was that, and that led to our aim statement, which is by the end of June 2019, we'll increase our transition rate to 70% within the first month of permanent hearing loss identification. Jacob Edges, epidemiologist from ICES, has helped us look at our baseline data in different ways in terms of timeline. For example, within 1 month of permanent hearing loss identification, within 6 months, within a year. So what was the transition rate? When we looked at within 1 month of identification, our baseline was at 14%. If we look at the time frame within 6 months, that actually increased to 43%. But it's also interesting to see that children who were transitioned were overall more likely to be transitioned within 6 months. Once the 6 months mark has passed, it's less likely to have the transition happened at all. Just another disclaimer is that when we talk about transition, we're not saying that the families will no longer be with the infant hearing program anymore. So they wouldn't be with the infant hearing program only if they age out. So we offer services up till 6 years of age, or they moved into another region. So it will be transferred to another regional infant hearing program. In terms of timeline, then all this data, it reaffirms our theory that we want to have that offer of transition to take place in a timely manner, which will increase our rate of transition. So some of our change ideas included creating a script for the audiologist to offer transition to PTSD at the first identification appointment, an online portal to complete that transition, and also a sticker to be placed on existing data forms to let us know whether that transition occurred or not. And also a checklist for the ones that didn't have the transition at all, then what were the reasons, so the audiologist can report back. We engaged the audiologist to review and provide continued feedback to these generated tools. We also had 2 audiologists support us in our PDSA cycle when we were creating the online portal. We were able to implement these change ideas in mid-December. And as of now, for January, we have had 7 children newly identified with permanent hearing loss. And of that 7 children, 4 of them have been successfully transitioned to the services. So that's a 57% as compared to the 14% that we were looking at when we were looking at baseline. So Joanna, what are our next steps?
So I know every one of us in this room are very well aware, just because we're graduating doesn't mean our project ends. And our little team of eager beavers, we actually have scheduled monthly meetings till the end of the year. But some next steps that we're very excited for is to continue to monitor the implementation of the ideas that Leslie had stated, the audiologist script, the online portal, the transition sticker, and the checklist, and just to incorporate feedback as we do receive the feedback for those. We'll also be doing ongoing monthly communication between Toronto Infant Hearing Program and Provincial and Demonstration Schools branch. So we're specifically looking at the percentage of successful transitions to PDSB of families. And on the other end of that spectrum, for families who decline services, we will want to follow up and see the reason that they are declining and change the process as needed for those families as well. And with any QI project, we'll want to continue to sustain and spread our findings. And lastly, looking back, we set out to improve the journey of infant hearing program families, and all of us actually have been on a journey of our own with quality improvement. And we didn't know what we didn't know at the beginning, and we definitely had a lot of unknowns. Initially, we didn't have data that showed the accurate transitions from our program to the PDSB. And we don't have databases that communicate between our two agencies. And at the beginning, we did have a lead audiologist on our core team. Unfortunately, she did have to withdraw. So this prompted us to have very creative ideas as to how we're going to roll out certain change ideas and get engagement from the audiology team. Also, there was several new protocols that was put forth to audiologists. So this also competed with the rollout of our change ideas, and these are the frontline staff that we're really looking to be able to implement them. And lastly, our advice for anyone starting a QI journey is just do it. We're all very busy professionals in this room, and there is never a great time to start a quality improvement project or to apply to the advanced learning program, but it's a solid foundation in any agency, and we are definitely living proof of that. And we've also been able to really increase our relationship with Provincial and Demonstration Schools branch, and we'll continue to do that. And I know from both ends, we're very grateful for that. Thank you.
Excellent, thank you. What are you curious about?
If you were 100% successful and all families were connected, would PDSD have capacity? Because that's a pretty significant increase in referrals. And so if that happened and you were remarkably successful, would there be unintended consequences on that end?
It is definitely something we've considered as one of our balancing measures and have had lots of talks with our executive sponsors about that. We have mechanisms to manage that. We've actually changed the way that we deliver service. Historically, we used to just do home visiting services as a primary course of business. And now we're looking at varied intervention levels and streaming families differently based on need, offering playgroups, having play and learning centers. We're actually opening up another one in Belleville in April, having small local community groups, offering newsletters for families and evening workshops so that it's a tiered approach. It's not just a one-size-fits-all. So we have modified the way that we do business, not because of this project only, but as an evolution within the service itself.
Thank you.
Excellent. What else are you curious about? You can't say what's for lunch. Come on, you're curious. Francine, go ahead.
Not a question, but that skit at the beginning was on point as a parent who sat there in the waiting room. The only criticism is that we never remember the full words about anything. It's just the acronyms, so.
Thank you for reminding us of that, yes. We're a little acronym heavy, right?
Yeah.
And an observation that from myself is that often when you're working with a different ministry, there is a whole new set of acronyms that you're not familiar with, right? Did you find that? Yeah.
Also procedures and approval processes, it's all quite interesting, for sure.
Yes.
And to your point, the whole reason behind this project was because parents were coming forward saying, I don't know what I'm missing, I don't know what I'm supposed to be doing. And now actually, there are so many projects that are ongoing, and one of them is a Welcome to IHP project that is being led by parents. So we've got a lot of interesting things on the go.
And if I could just say, my program is provincial in nature. This is the Toronto team that we've collaborated so beautifully with. So now our greatest challenge is that sort of local adaptable change for the other regions across the province, how we implement this to other regions. Because in other regions, we get less than 5% referral. So that's our big challenge next as we move forward.
Excellent, thank you very much. Well, yes, make sure your whole team gets in the photo, yes. So as this group receives their certificates and gets their photo done, I encourage you at lunch to have a walk around the posters. You've heard from all but 2 of the posters that are in this room so far. And maybe you can get a sneak peek to the afternoon's presentations as well. Plus, the other 8 teams' posters are just in the other room, and this wall is going to come up. So you will be able to get a walk around because you're probably thinking, oh, I wonder whatever happened with that XYZ program. We didn't get a chance to hear from them this time. So please use the lunch hour to reacquaint yourself with some of those and with the folks on the other side of the wall. And so with that, we will take a break for lunch. We're back right at 1, and we do have to start at 1. So if you could kind of be back about 5 to 1, and we'll let the first team get up here and get settled and get our process rolling again. The wall has to go down again because it's going to come up. So that'll give us a few minutes to make that transition. But thank you so much to the folks who went this morning. Great job. And we look forward to our 2 presentations this afternoon as well.